As you probably know, in the last 20 years, we are able to afford more TVs, computer software, new cars, but it's harder and harder for us to afford the medical care services and especially hospital services. If you look at this graph, the prices increased to about 200% compared to all the other things that became more affordable over the years. And the rising in healthcare costs did not wait only on the worker contribution, but also on the employer contribution. And I found this graph that was showing the difference between 2009 and 2019, where a worker, one member of a family that is working, it will contribute about $3,000 in 2009. And that contribution increased to more than 6,000 in our days. And on top of that, many of the workers, they do also pay high deductibles. And the same happened in the employer side, and they actually started to pay more and more and more, and that became a huge burden for the business side. And unfortunately, the traditional system did not help the patient or the physician. And on the patient side, we do see higher costs for everything. We do see longer waiting time. We see that patients have less and less access to specialists. And on top of the fact that do pay co-payments and their deductibles and their premiums, they do encounter a lot of surprise bills. And when they look at the bills, they see that the prices of labs, imaging, and medication increased tremendously in the last 10 years. On the physician side, we have less and less time with the patient. We'll talk about that in more detail. We have more time to document more than we spend with the patient. We get less reimbursement. We have no control, absolutely no control, or no idea about the cost that the patient will pay for our consultation, for the labs, for the imaging, for the medication, which I believe is not, it's not the right thing. And definitely many of us, we have no control on our schedule. And you think that increasing prices will bring better access, will bring more transparent cost. And actually, that didn't happen. And the question is, if we don't benefit as physicians, if patient doesn't benefit, who benefits from those increases in costs? And when I look at the Association of American Medical College, they publish a survey with how many specialists there are in the United States. In 2019, there were about 900,000 specialists in the United States. But some specialties like mine, rheumatology or allergy or pulmonary or sports medicine, they are very little represented. There are very few specialists. And when you look at the pediatric side, subspecialties, those are even worse represented in those numbers, in that 900,000 number. And that translated in more time, more waiting time to see a specialist. I was only able to find this report from 2012, and I know that right now the numbers look worse. With the time that a patient is supposed to wait to see a specialist. If you look here, if you want to see an allergist, the average waiting time is about 60 days. If you want to see a gastroenterologist, that time will increase to about 100 days. If it's even worse if you want to see a neurosurgeon. And for my specialty, the average waiting time is about 90 days. And of course, to accommodate that, patients had to be seen. And what happened is on each specialist, the load of patients increase. And in our days, we are expected to see between 20 and 30 patients a day per specialist, which is a huge number if you want to address complicated medical history. And those numbers, those physician shortages will not improve actually. And it is expected that in the next 10 years, those projections to go up to a shortage of 139,000 physicians, which will be both on the primary care side, but also on the specialist side. And the Medicare population is increasing. If you look today, in a medical specialty practice, about 46% of patients, they have Medicare coverage. And it is expected that in the next 10, 15 years to increase to about 55%. But many physicians that we see active today, about 400,000 physicians will retire in the next day. And the question is, who will see those patients? And if you look on the West Coast or on the East Coast, there are more specialists. But if you look in the rural areas, there are very few specialists living there. And unfortunately, those numbers will increase, the shortages will increase because Medicare is the largest, probably the main supporter of graduate medical education. And only this survey in 2021, I want to show you that although they had released 38,000 positions, the number of applicants was 10,000 more for medical school graduates. So a lot of those graduates, they remain without a position. And that happened because in 1997, Medicare actually put a cap on the number of residents that where they wanted to support or they were able to support each year. And that number did not change for about 20 years. In 2021, probably because of the pandemic, they added just 1,000 new Medicare funded positions. And on top of that, we do have a lot of barriers. After we graduate, if you want to practice in multiple states, you are not able. You have to be licensed in each state that you practice. And that will translate into a lot of expense for a physician. And that expense doesn't end when you license for the first time. You have to renew the license every 1 to 2 years, which is, again, limiting the scope of our practice. And to make things worse, Medicare reimbursement decreased over the last 20 years was about 30%. And if you look at the rate of inflation, what you could buy 20 years ago was $1, you just buy 60% of that amount these days. All of those things, they caused physician burnout. And as you probably heard, about 10 years ago, nobody was talking about physician burnout, but today there are more and more people that recognize that physician burnout is a system problem, not an individual problem. And burnout affects about 1/2 of physicians in practice. And burnout results in medical errors, lower quality of care, and definitely higher cost and overall worse outcome for our patients. So if you ask patients, if you ask residents in their first year of residency, about 50% of them, they will say that they feel depressed about the situation that they are in there. But over the course of the training, about 42% of residents will report depressive symptoms. And unfortunately, and that's very unfortunate for our profession, there is an estimated number of 300 physicians that will die per suicide per year. So the question is how to make things better or how to reunite back the patient and the physicians. And, direct care is not a new concept. We are not reinventing the wheel, but I think we bring back what is important for the physician and the patient in this relationship. And because I look at my specialty and there I know the most, I thought about starting a company that will provide this kind of services. As you know, rheumatology is in low supply and high demand. And as I presented to you, the waiting time, the regular waiting time is between 4 and 6 months if you are close to a big center. But the prevalence of diseases that we treat is increasing. And this is a graph published in 2017 about the number of patients that will have a diagnosis of arthritis. So in 2010, there were about 50 million, and that number is expected to increase to 78 million patients with arthritis, not autoimmune disease, which is another increase. And most of those patients, besides the fact that they need a rheumatologist, because of the nature of our diseases, they might need a second opinion, or they just need to be monitored for their treatments. So I started this company with the idea to broaden access to patients that they need rheumatology services. And in time, I expanded the scope to 9 US states. And on top of the fact that I wanted to open the doors for my specialty, I wanted to make things different. So that's why I went to Dr. Flaspoller and I started to tell him how I see things for my specialty, how I would like to create a system where I have the time that I need with the patient. I have, direct communication with the patient. I could see everybody and not limit the scope of my practice contracting with certain insurances. And I want to have transparent and accessible pricing. And I did relate to him the situation that we have in Romania, where you have the public sector where there is very hard to find what you need. And then you have the private sector where when you need a consultation or you need an imaging study, you have the prices all discounted at the door of the physician. So I wanted to create something that will be a direct specialty practice. And we talked about the direct primary care. And I started to think very seriously, how can I recreate that model into the specialty work? And later on, I will tell you the story of a true patient that came to me to be evaluated for an autoimmune disease evaluation. He had a very high deductible, so he already checked the prices that he would have to pay. And I just want to present you a comparison between what he would get in the traditional healthcare and the prices that he would be expected to pay, or his insurance to pay, or before his insurance kick in, he has to pay, and the prices that he would have to pay through my company. So on top of the consultation, the labs, the imaging, and I added everything that they needed, or the medication, he would be expected to pay between $7,000 and $13,000. Through my practice, he was able to get labs to a very discounted price. He was able to get imaging to a very discounted price, and he was able to get medication for a cash price of $100. So a maximum cost of $2,000. And now I would like you to multiply those numbers with 52 million of arthritis patients or 23 million autoimmune disease patients. And those numbers will be huge. Those savings will be huge. But I'm not the only one in this space. And I was able to identify, in the last 2 years, I was able to connect with a lot of physicians that are trying to do the same thing as I do. And I just put a few people that I've met over the last 2 years. But as we go into this movement, there is huge interest from other physicians to join this way of practicing and actually practicing medicine. So we were talking amongst ourselves how to scale up this direct specialty movement, how to put the patient first, really put the patient first in the center of our care, how to make prices transparent, how to make this relationship between the doctor and the patient forward like a direct communication, to make the patient accountable and the doctor accountable, but on the same way to remain autonomous and accessible for our patients. So we started this Direct Specialty Care Alliance with the mission to serve our patients. And the scope will be, or the vision and the mission will be to lead this movement of physicians, specialist physicians, to become independent and provide direct care services to their patients, to educate other physicians, to mentor them, and for them to be able to do or to practice medicine again to the highest level of quality care, and in the same time to remain accessible and to have transparent costs for the patients. We are to the point that we are connecting the dots. We have many things to learn. We have many things to discover, but the more we are, the merrier will be. And we put together a map that will help us identify where we are, will help us communicate to each other, and will help our patients to also find us easier. So the advantages will be to create a network or a community of direct specialty physicians, to educate others about their options to practice medicine, and to make those services, our services, available to patients that are interested in free market, and also make those services available for self-insured employers. And with that, I would like to thank you very much for this opportunity to talk today.